This video is about pericarditis, and what I want you to focus primarily on is the response of the pericardium to an insult. We're going to talk about a few of the etiologies up front, but it really doesn't matter for the most part what the etiology of the pericardial disease is. It matters instead what the pericardial disease is doing to the body and its response. We'll see what I mean in a minute. Let's go through the framework of the potential causes of pericarditis, but then we'll get into each individual disease in a bit more detail. So as far as causes go, infection is high on the list. And you can have all the standard variety: bacterial, fungal, viral, and TB. Now, in the US, viral is where the money is. Autoimmune disease can do this too: rheumatoid arthritis, lupus, the Dressler's syndrome. This is a post-myocardial infarction pericarditis, and uremia. Here's the other one you want to pay particular attention to, and we'll see in a minute why. Trauma is another big cause. This makes sense, right? If you stab someone in the chest and you create a hole in the pericardium, or in the worst, the ventricle, and blood starts pouring out into the pericardium, you're going to get a pericardial disease. So what you're looking for is penetrating trauma. It's definitely worse than blunt. Also look for aortic dissection. That is, the aorta dissects through the aortic valve, and all of a sudden with each heartbeat, the blood is pumping into the pericardium. These are generally particularly sick patients. And finally is cancer. And the type of cancers that are going to cause pericardial disease are going to be the ones that are near the pericardium, so in the chest. I want you to think about things like breast cancer, lung cancer, esophageal cancer, and lymphoma. So you can see that this list is quite long already, and it is not all-encompassing. You can spend a lot of time memorizing this stuff, and you can see I've blown through it because it doesn't matter. What matters instead is the pericardium's response to the insult. And there are three diseases you should be paying attention to. The first is pericarditis. And you may have noticed the itis ending. Pericarditis is an inflammatory disease, and so, not surprisingly, would require anti-inflammatory treatment. The second is a pericardial effusion. In its worst form, tamponade. This is a hemodynamic disease, and so is going to require a hemodynamic intervention. And finally, if that inflammation goes on long enough, you get constrictive pericarditis, which is an anatomic problem requiring an anatomic solution. So this is what we're going to talk about primarily moving forward. So let's start off with number one, pericarditis. To set you up with a model, remember the heart, the ventricle, is surrounded by a pericardium. And for the most part, there is no fluid in between the pericardium and the heart. Pericardium and myocardium are right up next against each other. There's some lubrication. It's a theoretical space, but there's no fluid. What could happen in pericarditis is that this sac, the pericardium, gets inflamed. Now remember, we're not going to spend a lot of time on pathology, but the two you should pay attention to are viral and uremia. The patient is going to present with chest pain. Remember, this is an inflammatory process. The pericardium is inflamed, and every time the heart beats, it's rubbing up against the pericardium. That's going to cause chest pain. But the chest pain is both pleuritic and positional. If you take a big deep breath, ow, ow, it hurts. If you lean forward, you relax the pericardium, doesn't hurt as much. If you lean back, you stretch the pericardium, it hurts more. It is both pleuritic and positional. For the diagnosis, people think, oh, it's the heart, so get an echo. For pericarditis, an echocardiogram is absolutely wrong. You cannot see inflammation with an echocardiogram. So you have to use different imaging modalities. Now the best test, which you're probably never going to get, is an MRI because it shows inflammation really well. The first test, and the only test you need, is the EKG. We'll talk about what that EKG looks like in just a minute. If you're diagnosing pericarditis, do not choose echocardiogram, choose EKG. If you're asked specifically what's the best test for this diagnosis, MRI. The treatment has changed in recent years, and so I want you to pay particular attention to this. Your options are NSAIDs plus colchicine, NSAIDs alone, colchicine alone, and steroids. You can see that this makes an excellent test question. The best choice is NSAIDs and colchicine. The question becomes, can you give these? NSAIDs cannot be given in CKD, thrombocytopenia, or peptic ulcer disease. Now, technically, they could be given with ulcer disease with a PPI, but stay away from NSAIDs if you have bleeding problems, low platelets, or CKD. Colchicine is dose limited by diarrhea. And steroids are absolutely the worst choice. You can use them if you have to. That is, if it is refractory to NSAIDs and colchicine, you can go to steroids. But otherwise, steroids are not the answer. And the reason why that is because the recurrence of pericarditis increases with the use of steroids. And this is particularly true for viral pericarditis. Stay away from steroids. Now, of course, if this was uremic, that is, they have renal failure and they have not been dialyzed, you simply could dialyze them. Hemodialysis would be curative of a uremic pericarditis. So what's up with this EKG? What are you looking for? A normal EKG has a P wave, PR interval, QRS, and a T wave. On an EKG, you're going to get a 12 lead. If you see diffuse ST segment elevations everywhere, not just in one location or two contiguous leads, but everywhere, pericarditis. You're done. Diffuse ST segment elevations is pericarditis. But the thing that's pathognomonic is a depressed PR segment. I'm not going to get into why. If you see depressed PR segments or diffuse ST segment elevations on an EKG, it's pericarditis. Pick NSAIDs and colchicine unless you've got a contraindication. Inflammatory process, anti-inflammatory treatment. As we talk about pericardial effusion, we have to look at the ventricle. And it has a pericardium around it. Theoretical space, no fluid. If there's a little bit of fluid that develops, there can be some impingement on the ventricle such that the ventricle itself effectively becomes smaller. Now, this is not a big deal if there's not a lot of fluid. If that fluid has accumulated slowly or there's not a lot of it, you just get a pericardial effusion. Most often, a pericardial effusion is a product of the pericarditis. Now, I'm going to pause for a minute here because I want you to keep these two things separate as you start to clinically reason. Pericarditis is inflammatory and causes chest pain. Pericardial effusions are fluid, not inflammation, and cause shortness of breath. Realistically, most pericarditis will have a pericardial effusion, but not every pericardial effusion is a product of pericarditis. But in the setting of acute pericardial effusion associated with pericarditis, the patient is going to present with pericarditis symptoms. To see fluid, the echo is the test of choice, and the treatment will be to treat the pericarditis. But if despite treatment for pericarditis, the pericardial effusion does not resolve, that is, they come back later and a recheck of the echocardiogram demonstrates, hey, there's still fluid here, you may need to do what's called a pericardial window. It's a surgical intervention where literally you just take a piece of the pericardium away, and this allows the fluid to drain into body cavities. And it's only significant because there's a little bit of fluid around the heart, and that matters. That little bit of fluid in the chest, body will reabsorb it. No big deal. Now, on the other hand, if what you have is a rapidly accumulating fluid or fluid that has accumulated a lot over a long period of time, you get something much worse. And so it is not the volume of fluid or the time it takes to accumulate, it's both. If there's a lot of fluid, the heart can accommodate, but eventually it can't accommodate anymore. And if it's rapidly progressive, the heart won't have time to compensate. This is a pericardial tamponade. Tamponade is a clinical diagnosis. The patient is going to present with CHF symptoms. What happens is all of this fluid is pushing on the heart. The left ventricle is big enough to manage, so it's not going to be bothered by it all that much. But the right ventricle is weak and is easily crushed. So essentially, this is a right-sided heart failure. So what you're going to see is jugular venous distension and hypotension. And because there's all this fluid between the heart and the stethoscope, decreased heart sounds. This together is called Beck's triad, indicative of pericardial tamponade. But because it is heart failure, but the blood can't get through the right ventricle, you're going to have clear lungs. And the thing that makes the clinical diagnosis of tamponade is pulsus paradoxus. Pulsus paradoxus is a normal phenomenon unless it's greater than 10 millimeters of mercury. What you're going to do here is say, okay, I've diagnosed pericardial tamponade clinically, I know what to do. Since it's a pericardial effusion, I want to get an echocardiogram. And maybe since it's a pericardial effusion, I want to do a pericardial window. That's fine if they're already on their way to surgery, but this is not the right answer. You do not stop to get an echocardiogram. You don't wait to put in the window. If you see pericardial tamponade, the right answer is pericardiocentesis. You put a needle and drain that fluid out. You take the tamponade and put it back to a pericardial effusion. Now, it is possible that you don't have the kit ready and the OR is not coming. The first thing you should do is give intravenous fluids. A bolus of intravenous fluids will increase the preload. It's going to push open the ventricle so that it gets a couple of good beats to get the blood pressure up. It's temporizing. It's not the right answer on a test, but it's the right answer in life. And so if you can't get them to the OR fast enough, bolus them with fluids and grab a needle, stick it in their chest. Hemodynamic problem, hemodynamic solution. And lastly, we have constrictive pericarditis. This is actually a far more complex disease than I'm letting on. But basically what happens is you've got the heart, the pericardium around it, and after repeated inflammation, pericarditis after pericarditis after pericarditis, the inflammation becomes scar. And so what you have is this rigid box. During systole, when the heart contracts, no big deal. But as it expands in diastole, you get a pericardial knock. And this is a very complex way of disease, but what I want you to see is the pathology is going to be pericarditis, recurrent or repeated. The patient is going to present with diastolic CHF and a pericardial knock. The diagnosis is going to be made with an echocardiogram, and the treatment is pericardiectomy. You can't undo the anatomic change. It's scar, so you just cut it out. So here's how I want to put it together for you. Constrictive pericarditis, Pericardiectomy, remove the pericardium. Pericardial tamponade, pericardiocentesis, stick a needle in it. Pericardial effusion, treat the pericarditis. Unless it's recurrent or refractory, then do a pericardial window. Pericarditis is treated with anti-inflammatories, NSAIDs, and colchicine being the best. And that is pericardial disease.